Welcome everybody to the Colorado Integrated Food Safety Center of Excellence webinar. So we bring these on a routine, if slightly irregular schedule, to bring you topics around food safety. And I think an important topic for me and for many out there is just understanding the burden of foodborne disease and understanding the economic cost associated with those illnesses. So I'm delighted today we have a real expert in this area visiting with us, Sandra Hoffman, who is from the Economic Research Service of USDA. So Sandra I've known for a long time. She's worked on many different projects both in the US and internationally, and today she's going to focus on a project that was just recently completed as part of the World Health Organization initiative to estimate the global burden of foodborne disease. And she's going to talk to us a little bit about that, but really looking at the attribution of those the illnesses to food. So with that, I want to welcome Sandra, and thank you.
Thank you. Thank you very much. And a little bit of background, partially about why USDA is interested in this. So the Economic Research Service is a research office within the Department of Agriculture, much like our agricultural research stations might be doing biological research. We do economic research, and we have a long history of estimating the social costs of foodborne illness and looking at foodborne illness and its impact on consumers and consumers' response to outbreaks in the US, and work on trying to evaluate the effectiveness of food safety programs in the US. My personal work is focused on health valuation and especially the problem of attributing foodborne diseases to their food sources, because to do anything about it, we really need to understand where the exposure routes are, and even to do economics in this area, we need to understand those exposure routes, and that wasn't being done. So it was an area I got involved in early on, as we need to have those numbers to do the economics. Well, I'll learn how to do that. Today I'm talking about the recent global burden of foodborne disease estimates, and I think one thing that's really interesting to know is this is the first time we have ever had estimates of how many people are getting ill from foodborne diseases around the world. And it's been a very significant and long process. It began back in 2006, so it's been a 9-year process involving, well, over 100 scientists have been involved in this. The WHO wanted to get estimates of the incidence of foodborne illness globally, but by region, and actually the estimates are now by country, as well as a measure of burden. And I'll be talking a bit about that, which some of you may not be familiar with. But one of the challenges, one of the reasons we need both economic and burden estimates is because these diseases have a wide range of health impacts. And it ranges from kidney failure to 2 days of mild diarrhea. So how do you compare those and say something coherent about the overall burden? And WHO is using disability adjusted life years, a measure that was developed specifically for estimation of the global burden of disease, as that effort started a decade or two ago. In addition to having estimates of incidence and burden, we need to be able to attribute that to food and to attribute that to specific food exposures. And the other WHO desire was to develop tools that countries can use at the country level to help improve management and policy around foodborne disease. So this hasn't been done before. As I say, this is the first time we're having world estimates. We're dealing with many different agents and relatively poor data in many parts of the world on just the epidemiology of those diseases. In terms of attribution, the whole attribution process is quite complicated. I'm just going to go through all of these. A large part of that is for For infectious diseases, because those infectious diseases can be, often are by exposure routes in addition, that evidence is often just, in addition to the problems of underreporting and just a lot of the disease not coming to of public health authorities, even if it does, trying to get evidence on what is actually causing it. Is it food, or is it human-to-human contact? That evidence is often destroyed with latency periods in the infectious process. By the time you figure out that you're sick and are heading to a doctor, you don't remember what you ate. The evidence that the food's been eaten or destroyed. So it's very difficult to get that evidentiary base that's needed. And in fact, I was talking with a colleague. We started out at Resources for the Future together, Majid Asadi, who's very involved with the overall global burden of disease effort. And he said the main reason why they had not taken this on before was the problem of attribution, that they just couldn't find within the methods that they had been using a way of getting at quantitative measures of what proportion of, say, salmonellosis is due to food as opposed to another route of exposure. And of course, the difficulty of just lack of data worldwide on this. So today I'm going to give you a brief overview of the study. I'm not going to focus on the disease incidence and burden estimates. I hope that Ari Havilar, who is the chair of this whole effort, might talk with you about that at more length in the future. I'm going to focus on source attribution since that's what I did. But of course, I know many of you actually want to know about the results, so I will talk to you a bit about the results, and then some ideas on how those can be used to improve food safety, food safety policy and prevention of foodborne illness. So study overview. It's a large project that involved, as I say, over 100 scientists. It was organized around a series of hazard-based task forces. So the Enteric Disease Task Force, or parasitic or chemicals, did the disease incidence work and the burden of disease estimates. The source attribution task force that I worked with did the source attribution, and then we have country studies, and the computational task force put it all together under the great leadership of Ari Havilar. He did a lot of work. So we have global estimates for 31 foodborne diseases: viruses, bacteria, protozoan, parasites, other parasites, and chemicals. Some of the major chemicals, particularly for developing countries. And for each of those hazards, the effort estimated the incidence of illness and the incidence of death. So it's taking future burden, it's measuring the future burden resulting from current exposures. And then for each of those illnesses or diseases, an estimate of the disability adjusted life years was developed so that we can compare across diseases. We use a reference year of 2010, so these numbers should be interpreted as what was going on in 2010, although the data that's drawn on is much more diverse than that. And the estimates are available at the country level, but what are generally presented in the public are at the WHO, or not WHO subregion, but they're at a global subregional level. And then once that incidence work was done, then we attributed that incidence and burden to food exposure or to specific food exposures. These are the regions, subregions for which we're going to be, you can easily get information. These subregions are based on child mortality, which of course is also highly correlated with national income and economic development levels. So just because many of you may not, I don't know if everyone is familiar with dailies. Okay, let me just go through that. So the basic, as I say, the basic problem is if we're going to try to understand comprehensively what the total burden is, or to compare burden across diseases that have very different outcomes, we need some kind of a metric that is comparable across those. As an economist, I work on economic valuation, which puts that into a dollar value that we can use to compare, and within both the healthcare communities and also increasingly in the population health communities, different quality adjusted or disability adjusted life year metrics are being used. So the disability adjusted life year metric was developed for global burden of disease estimation work. A daily is the loss of one healthy life year. It allows us to integrate both morbidity and mortality impacts into a single metric. And it takes into account both the occurrence and severity of disease. So graphically, what you can see is that it accounts, well, if I had a pointer, but the red area, if we it accounts for both loss of life expectancy. So a person who might have lived to age 80 only lives till age 50, they lose the entire benefit of those years. So that's a loss of one daily per year. But they may have also experienced a period of morbidity. So that's the green area shows a reduction in the quality of life during a portion of life. And that reduction in quality of life is reflected in the disability weight, or DW. So it's both duration of that period of morbidity as well as a severity weight associated with it. And so then the loss from being able to live in full health to age 80 is represented by the sum of the red and green areas. So both the loss of life and the reduction in quality of life. So I'm going to want to move on to the work we did on source attribution. So this is work I've done with Tina Held from the Danish Technical University, Willie Aspinall from Bristol University, and Roger Cook from the University of Delft and Resources for the Future. We did a large, really quite a large primary research study to get attribution estimates that were used in the global burden of disease work. We looked at two types of attribution questions. First is this a foodborne disease at all? And in that, we wanted to actually have estimates of the alternative major exposure routes. And then given that it was foodborne, which foods were causing the disease? The set of food categories that we use here are emerging as a categorization that's being used in various national studies, and using those again in the global burden study allows for comparison between those national studies and the global burden work. One of the issues in doing attribution work is you have to say attribution to what? To what point of exposure, and how are you going to define exposure? For the primary exposure pathways, so that's is it water, soil, food? We defined point of exposure, the point of exposure as being the point of exposure when it entered, when you came into contact with the disease agent. For the food attribution, it's foodborne, but which food? We took a different approach, which is different than what I've seen in prior attribution studies. Instead of saying exposure occurs when you eat it, we're attributing the disease to foods that were contaminated at the point it entered the place where it's being prepared. That might be the home or the restaurant or wherever it's being prepared. The reason for this is really a policy reason. That most food safety policy is focused on prevention of contamination. And the issue of the types of policy that address issues that can occur during food preparation, so cross-contamination, contamination by the people, human contamination of the food by people who are ill, are addressed by a different set of policies than the policies that are used to prevent contamination during food processing, food production. At the place of food preparation, it's really more of an educational effort an effort at hygiene within food preparation establishments like restaurants, as opposed to, say, care in slaughter, or what's going on the farm that's causing a bacterial infection, or policies that are affecting the use of pesticides in production. So it's really the policy that's driving the decision to have point of entry into the household or food preparation setting as the point of exposure. So I think I may be ahead of myself. I'm going to end up telling you that we're going to be using expert judgment, and then we're going to be using a survey of expert judgment to get our estimates. So my slides are a little bit out of order, but this is what, if you had been asked to participate in the study, this is the kind of question that we would be asking you for a particular hazard. It might be a pathogen. What percentage? What is your best estimate, or interpreted as a median estimate of the percent of exposure that was due to food versus water, for example? Or for foodborne illnesses, what percent was due to beef as opposed to other foods? And in addition to that, we asked for outer bounds on what you think it could possibly be. So that defined as a 95th and a 5th percentile estimate. So I'm just going to go ahead here because this is what I should have started with. The task force commissioned a review of various methodologies that have been used for attribution, and this is a very active area of research, and new methods are being developed. They range from microbial subtyping that Tina Held developed in Denmark, where Denmark has a really strong program of sampling throughout the entire food production chain, which is something that I don't think any other country really has that strength. So they have on-farm sampling in a processing plant, sampling when it gets to retail, and then you can compare the microbial subtype of that's showing up in the human illness and trace it back through the production chain. It's a very rigorous and quantitatively sound way of going at it. The problem is it's very data intensive, and so for our purposes, it wasn't going to get us very far. Outbreak analysis is used, investigation analysis is used widely. We have, I'd say, our attribution estimates in the US, the soundest ones that we have are based on outbreak analysis, and I'd say that's true in most of the high-income countries where there is really good outbreak investigation. But for most of the world, we don't have that level of outbreak investigation. Similarly, since the fundamental underlying primary data isn't there, systematic reviews aren't going to help a whole lot either. And then comparative exposure assessment is used a lot, particularly in chemicals, and was relied on in the global burden of disease work for a number of chemicals. So that's a process of modeling the risk generation process and to get an estimate of the likelihood of contamination and exposure. Again, it's very data intensive. So to be able to get comparable estimates across a wide variety of settings that have a wide variety of data environments, eventually we were going to end up relying on expert judgment. So the question was, do you rely on the judgment of the modelers involved in the study, or do you try to get information from a wider community of experts? And there's a series of methods, expert elicitation, that have been developed to do that in a systematic, transparent, and hopefully as rigorous as possible way. So let me now go back. So the area of expert elicitation grows out of a literature on the psychology of judgment under uncertainty that recognizes, that identified a number of consistent kinds of problems that arise when people are trying to make judgments under uncertainty. There's a tendency to be, individuals can have systematic tendencies towards being overly or underconfident about their estimates. They may also have a tendency to have to overestimate what risks are or underestimate what risks are. There's a persistent kind of problem across all of us in anchoring on recent information or salient information. So these are kinds of patterns in human judgment and decision making that are seen in the psychology literature on judgment under uncertainty. In addition, if we're looking at of multiple experts, there's the problem of you can have a problem. Early studies were done by bringing experts into a room as a committee and asking them to hash out their judgments together. There's also quite a good sociological literature on the problems of group dynamics. This is seen a lot. A lot of this work came out of focus groups and how group decision making goes on. So there's problems of group dynamics that have to be taken into account. So as a result, there's a number of methods that have been developed to try to deal with those problems in human judgments under uncertainty. The Global Burden of Disease Committee, kind of core committee, decided to focus on a method that was developed by colleague Roger Cook. And his approach to it is to say, okay, we can, the two approaches that have kind of been dealt with those problems of kind of systematic biases are to educate people about what those biases are and try to get them to correct their biases. That's one major approach. Roger's approach is to say we can do that, but we can also try to measure what those biases are and use that measurement of bias in aggregating judgment. So Roger's approach deals with the group dynamic problem by having by not using a group, by having individuals respond, and then deals with the problems of bias in judgment under uncertainty by trying to measure that bias. In particular, biases about, do you under or overestimate risk systematically? And do you tend to say, well, it could be anywhere from 0 to 100, or do you tend to say, no, I know it's between 20 and 25. That's it. So we all have these biases to one degree or another. And what he has done is to try to develop a method to measure those biases and then optimize the aggregate across the group. So we measure through using a set of calibration questions that I'll talk about in a moment. And then we use the responses to those to mathematically optimize the a joint distribution based on multiple experts. The optimal aggregation tries to optimize both how accurate people are and how informative their judgments are. And it could be that the optimal is an unweighted, just an unweighted average of all the experts' distributions. But usually it turns out that some type of what Roger calls a performance-weighted average will perform better. And in fact, we found in this study that we got better performance from a performance-weighted aggregate. The calibration questions are a set of questions that are substantively related to what you're interested in, because you want experts to feel comfortable. This is their area of expertise and they're comfortable with the questions. But they aren't really aimed at, we're not interested in knowing, do they know the answer to this, as much as we are, can this reveal something about tendencies that they have about how they respond to decisions under uncertainty. So it's important that the answers aren't known at the time of that they're answered. That creates uncertainty, but that they will be by the time we do the analysis, so that we can measure how well people are performing with regard to accuracy and informativeness. So, the ideal would be something like the future value of a time series that they're used to working with. In the problem of global burden of disease, we don't have those time series, and that's part of why we're dealing with this. So one of the challenges was coming up with a set of calibration questions that were both challenging enough to really create a condition of uncertainty, but related to substantively to the area that we're working in. So the problem of attribution is really an integrative problem. There are many things that could affect whether a food is contaminated and whether someone is exposed. So it's everything from the way food is produced and processed, to sanitation and water conditions in the region, to food consumption patterns. All of that helps determine whether people end up getting exposed. So we looked at, because it is a broad integrative process, we used a broad set of questions for calibration. We used questions about the food supply to get at dietary patterns, roughly, because it's what we have on dietary patterns. Under 5 mortality, because it picks up, because it's important in itself, as we'll see, but also because it picks up information about sanitation conditions. We also looked at water and sanitation. Where it was available, we used disease surveillance data that was primarily for higher income countries. And then where there were systematic reviews, we also used information from those to develop these calibration questions. So here's an example of the kind of thing. They were pretty challenging to people. Willie kept pushing for having challenging questions because it creates more uncertainty. This is a question that was based on a systematic review, and could either be answered because you had read that and were familiar with it, or because you had other basis for thinking about what was likely to be the outbreak-related cases due to salmonella in China. That could have to do with your knowledge of salmonella and how it grows in foods. It could have to do with your knowledge of the likelihood that salmonella is an outbreak-associated pathogen, and it could have to do with your knowledge or lack of knowledge about conditions in China. What's important here is that we don't really care whether you know what's going on in China. What we care is, can you assess the state of your own knowledge? So do you have a sense of where that may fall, but also are you pretty good at assessing how uncertain this kind of an estimate is? So that's what we're trying to measure with these. Oops. So people were presented with, where is that? Okay, we'll go down here, sorry. I think I cut that slide. So people were presented with a set of about 10 of these questions per hazard. And then that was analyzed to both weight that person's performance on judgment under uncertainty, and then to aggregate, create an aggregate across experts on a panel. So we had a number. This was a unprecedentedly large expert elicitation, and so that created a number of challenges just from the perspective of expert elicitation research. One of the major ones is respondent burden. I do a lot of survey research, so that's one I am used to thinking about and contributed quite a bit on. How we could identify experts and the structures of panels, and then the implications of a global scope for elicitation administration. Respondent burden was the big thing. So we have 31 hazards. There's 7 possible primary pathways, 14 possible food pathways. That's up to 651 of those triangular distributions for each subregion. It's huge. You can't ask people that many questions. So we had to come up with ways of reducing that burden. So one way that was done was that the task force, which was a committee of subject matter experts on food attribution, looked at the hazards and said, can we rule out some of the pathways? So that was a judgment that was made at the research design level. We similarly did this for food pathways. So that resulted in quite a reduction in the number of questions that we had to ask people to respond to. So that what that means is those matrices of questions that I presented earlier were smaller, and it just reduced the burden of answering them. So identification of experts. The important thing to know about this is that we're not trying to sample the population of experts. We're trying to get a panel of people who have the best knowledge that we can get and who are good at providing judgments under uncertainty. So it's not a population sample. We went through this using methods for identification that have been used in social network sampling, but it's because it's kind of a standard way of identifying groups, membership in groups. So we did an iterative peer nomination process. We did try to start with a number of different starting points to start this iterative process. We asked professional societies, WHO regional offices, public health offices to provide initial nominations. We went to those folks and said, here's the problem, are the problems that we want to address. Who do you think would be the best person to address this? And then also self-nomination. WHO reviewed credentials and then ultimately decided on using the criteria that they've developed for identifying experts and finally chose people to invite. So we ended up then with we ended up then with several panels of experts. Focused both around most of the panels. So one of the things that we kind of came to as we were working through the design was the realization that we wanted the expertise to be regionally representative. We needed to make sure it's not just subject matter, but it's subject matter in a particular region. And one of the things that became clear as we started to investigate how do people do research was that people are subject matter experts and they do research in multiple places. So the fact that you're located in Sweden doesn't necessarily mean that you're not one of the leading experts on foodborne diseases in sub-Saharan Africa. So we're looking for panels that have expertise about the regions, not and about the subject matter. So we ended up by having panels that were global in scope, and people were allowed to bow out of responding for regions where they didn't feel they had adequate expertise. The only exception to that was for enteric pathogens, where water and sanitation conditions play such a major role and are so different between developing and high-income countries that we had two separate panels, one for high-income countries, another for developing countries. In terms of administration, the global scope of the study led to some changes in the way this is normally done. Normally, expert elicitation, the way Roger has done expert elicitation in general, how it's been done, is one-on-one interviews. That's not what just wasn't possible given the scope of the study. So instead, what we did was train a group of facilitators who were wonderful folks that mostly postdocs in areas that were related to the subject matter domain, and trained them on the survey and trained them on conducting the elicitation. So this was elicited through one-on-one phone conversations using Skype. The calibration questions themselves were answered during that phone call. And that was done as a way of, one of the things that's important in terms of that we're trying to get at judgment under uncertainty. So to create that condition, we both explained the importance of not looking for information to our respondents, and the function of those questions, that we in fact wanted them to be uncertain and wanted them not to have access to that information, and didn't expect that they would know these, that it wasn't about knowledge, it was about how do you give judgments when you're uncertain about something. And we controlled the information they had by having the questions answered, online, on phone with another person on the phone. So it would help limit any kind of cheating, looking for up the answer. But, the target questions we wanted people to have access to whatever information they felt necessary to actually give us the best judgments they could. And that we explained that included any information they thought was relevant, including conversations with colleagues. The instrument explained that while that was true, we ultimately did want their own judgment. So they were free to talk to anyone, look up any information they needed on the target questions. We gave them 2 weeks. It usually ended up being more like 4 to 6 weeks before we got a response, but they had time to sit back and think about those target questions. Okay. This is just participation and completion. The experts enrolled were the folks that WHO decided had adequate expertise. The experts interviewed were those that responded to the WHO invitation. Of those, we have, of the experts that said yes, we want to participate in the study, and we're able to contact them to do the interviews. Almost all of them completed. Yes.
Just a quick question. Of the experts enrolled by WHO, what was the universe that was offered to WHO to choose from?
So that's where I was talking about the identification of experts. So it was the universe of people that were identified through that iterative peer nomination process.
So I'm just wondering, so for brucella, for example, did you offer up to WHO 20 names and they chose 10? I'm just wondering what was the...
Yeah, I don't remember. I don't remember what, I don't have that with me. I don't think there was a lot of culling at the WHO level, because I think a lot of that had happened in the nomination process. So I think as people were nominating people, they really were considering, okay, who is it? I was involved in that, in fact, because brucella, for example, was an area where we were having trouble finding people. So I know that what I was considering, and I think it was similar to what others were, was, okay, who knows about brucella? Who would know who knows about brucella? Where do we find the best people in North America on brucella?
And just as a related question, were these the final hazard groups that WHO went with? So things like heavy metals dropped out, or is this just one slide?
No, this is not. This is actually, this slide doesn't have the heavy metals. Heavy metals did not drop out. Where do I have the? I may have to run through these to get you that, but it's not heavy metals did not drop out. And actually this also doesn't show the viruses, so apologies for that. Okay, so some results. First of all, on the performance of experts, what we found was that both a performance weighted aggregate and an equal weighted aggregate of respondents on each of these panels across the panels generally had acceptable statistical accuracy. The equal weighted tended to be have a higher level of statistical accuracy than the performance weighted, but the performance weighted tended to be have higher informativeness, and that's actually a pattern that Cook and Aspinall have seen across most of their studies. Combined, what we're interested in judging overall performance is the combined score of accuracy and informativeness, and on that level, the performance weight outperformed the equal weighted approach in 62% of the cases. So the ultimate decision was to go with a performance weighted aggregate. So this gives you an idea of, these are some of our attribution results for the main pathways. And Salmonella and Campylobacter are two of the pathogens that were heavily foodborne. So for attribution estimates, we do not have country level estimates. We only have sub-regional estimates. And this is the median, actually this is mean estimates, but we also have uncertainty. We have the full distribution for each of these, but this is just to give you a sense of the aggregate. And part of what this is showing is some regional variation in the roles of different major exposure pathways across regions in the world. So those attribution estimates then were, for food, for example, were used to apply to incidence estimates for salmonellosis, incidence estimates for Campylobacter, to say what percentage of salmonellosis in sub-Saharan Africa, or Africa D, for example, was due to food. Those then, if we wanted to, so what this slide presents then is aggregating up across all regions of the world. What the study found was that foodborne illness is a pretty significant, it's a pretty significant source of disease in the world. 600 million cases, 420 million deaths, and the daily burden is 33 million DALYs, which is among infectious diseases that puts foodborne illness about 4th or 5th. It ranks below tuberculosis. Malaria, tuberculosis, HIV are above it, but it's a pretty significant burden globally. And as you'll see that the chemicals are in here, but the major component are diarrheal illnesses. So these are some of the most frequent causes of foodborne disease globally. For illnesses, of course, norovirus, as you would expect, but also Campylobacter. For death, non-typhoidal salmonella, Taenia solium, hepatitis A virus, and aflatoxin. And in terms of the disease burden, salmonella and enterotoxigenic E. coli, as well as the Taenia and norovirus and Campi. So some of the things that we're used to seeing, if you're used to looking at U.S. figures, some of the things that we're used to seeing here as major problems also are major problems globally, but issues that aren't considered to be major problems here, such as aflatoxin, are major problems when we look at it globally. And that should not be there. Hang on. Shoot, can I get rid of that for you? That was, so, sorry, slideshow. There we go. All right, so let's look at the region. This is some figures for regional distribution, and this is the DALYs per 100,000. And what this is showing is that Africa and Southeast Asia have considerably more burden per 100,000 than even say Latin America, which you might, the patterns very much follow patterns of economic development. The other thing I want you to notice on this is that this is for all ages, and look at, for example, Africa D, the number of DALYs per 100,000. For all ages, it's 1276 DALYs. If we look at children under the age of 5, the regional pattern is similar, but look at the DALY loss, 3,200. So it's almost double for the value for all ages. So another slide to look at regional differences. So what we see here again is that if you look at the subregions D and E are the subregions with are the low income or high child mortality and generally low income subregions. And so we see that Africa, sub-Saharan Africa, the poorer areas of the Eastern Mediterranean and Southeast Asia really stand out as regions with the most burden. So some important, just some very basic things that come out of this. Children under 5, that the burden is disproportionately distributed across populations. Children under 5 experience about 40% of the daily loss globally, but they're only 9% of the world population. So children under 5 are disproportionately impacted by foodborne disease. Poor people are disproportionately impacted by foodborne disease. 75% of the deaths, 72% of the daily loss, but only 48% of the world population. So this is a problem of the poor, and it's a problem of children. And what you can take from the slide about regional differences is that given current technologies, current management processes, this is a manageable problem. It is preventable. But it is not being prevented in those areas of the world that are most economically challenged. So that's a basic important finding from this whole large effort. I'm going to go through this quickly. So just how can we use this? Well, first of all, I think there's an importance in continuing to push on food safety, the link between food safety and food insecurity. Food insecurity gets a lot more attention in the developing world, and I think there's a tendency not to see food safety as part of that picture. But as I like to say, it is not enough to get the food in people's mouths. It has to actually nourish them. And if it's causing them to be ill, you're not achieving the nutritional goal that you're trying to achieve. And hopefully these numbers will help make that case in international health circles. Again, I'm going to go through this quickly because I want to get to some questions. I think that one of the things that comes out here also is that mycotoxins are pervasive, and with global warming, that's expected to increase as a problem. So it already is showing up as a pretty significant chronic disease problem, and it's only going, we know is probably going to get worse. So how can this work be used? I think part of it is that coming out of one of the things that Codex Alimentarius has done is to develop kind of global consensuses about global thinking about how do we manage foodborne disease. And part of what's come out of that is to think about it as how do you manage a risk, and using risk analysis and various risk management processes to help push risk reduction. The information that's developed and has been developed in the global burden of disease forms a foundation for that kind of analysis. It can provide a foundation for developing better information at a national level, for showing where public investment is needed in epidemiology, in risk management, and how, it's a starting point for understanding where we can intervene most effectively. Let's see. Okay, I'm going to skip over these next few slides so that we can just move on to questions. There are a number, if you're interested in this area, there's some nice resources that you can look at. The WHO has a really terrific website that has the main report. It has some educational materials. So if you wanted to do education around this, it's got some nice materials. There's a nice interactive mapping module that I used to, some of those regional maps that I generated and graphs can be generated. So if you want to do some educational work around this, it's great material to work on that. The papers, all of this is undergirded by a large number of scientific papers. They're not all done. I'm currently working on the one for example, for the food attribution of foodborne disease, but they can all be accessed through the plus one collection. This is the interactive mapping tool on the WHO website, and an example of some of the types of educational materials that you can find on the WHO website. I have to acknowledge that this was a huge effort, involved hundreds of people. So what I'm representing here is the work of a lot of other people. And what I did was a piece of it, but it's a lot of people's work. And we
Yeah.
got a tiny time for questions.
Great, so we've time for a couple of questions, so if there's any in the room, and then if you can chat through Zoom, we can also take some for those of who are joining us via the webinar. Any questions here?
How did you take account of the fact that, especially with children, they have different types of susceptibility to foodborne illnesses?
Would you mind repeating the question?
Sure. So the question was, how did the effort take into account differences across the under 5 population in susceptibility to illnesses? And I'm afraid I'm going to have to punt on that since I didn't do the incidence work. I know that they built off of the work on under 5 diarrheal illness and death. But again, I think this is a huge project. I think try to get Ari here and he can address.
But that's an interesting question because they probably differed in terms of transmission rates too.
Yes.
For certain diseases, you would expect children to be more likely to be exposed to the environment or contact with animals.
Yes, absolutely.
They're not maybe eating some of the foods that.
Yeah, absolutely.
Well, and I was thinking particularly of malnourished children having greater susceptibility.
Yes. Yes, so there's that interaction between nutrition and infectious disease, definitely. Yeah.
Geez, I'm not quite sure if I thought my question out very well, but I was curious about developing nations where you're at that place where they've gone from eating what they could locally to now having a little bit more disposable income and eating out more, where maybe the safety infrastructure is not necessarily in place. Was there any? Did anyone look at anything like that?
Well, there was a task force that was focused on country studies, and I'm afraid again I'm going to have to punt a little bit because I wasn't involved in it. But I know that their charge was to look at how does one take this information and then use it as a foundation for helping to build better information systems on management, and certainly hygiene within food preparation areas is certainly a growing issue with rapidly urbanizing. Most of the developing world is rapidly urbanizing, so it's an increasing. So the issue of hygiene in restaurants and markets and such is definitely a growing issue. So they attempted to try to address those through the country studies.
Yeah, and having worked on something similar for the US, I know that this type of activity highlights a lot of what you don't know and what the data gaps are.
Yes.
And I think with whether it's in specific high-risk groups or risky behaviors, I mean, you can slice and dice this so many ways. I think everybody that was involved in this is really to be commended because it was such a huge project, and I'm sure it has spurred a lot of recognition for data gaps and future projects to address some of these.
Yeah, and like the numbers we have in the US, there's a lot of, I mean, this is an area where there's a lot of uncertainty, and kind of like the early numbers in the US, like I'm thinking about Paul Mead's work, you got to start somewhere. So this is the start. At least we have an initial picture of what's going on. And then there's a lot of detail and a lot of data quality to be built into it from here forward.
Lee?
Is there time?
Yeah.
So I have an interest in the inherent biases that the foodborne illness community has towards the recognition of infectious sources versus non-infectious sources. So that's my context for my question.
Yep.
And I'm wondering, when it came to identifying your panels of experts by category, was there the same level of gradation in the non-infectious cause side? So the way that you've broken out by bacteria probably breaks out into like 15 different categories. Experts on lead actually aren't necessarily experts on cadmium, chromium, et cetera. Did you have the same kind of range in terms of those? Because I was sort of struck by what I think is probably the under attribution by the panelists to the non-infectious contribution.
I think there was certainly, you can see that bias in the number of, I think partially in the number of hazards that are included in the chemical side. The chemical task force ended up not using the expert elicitation approach as much. They felt that they had stronger data on exposures and certainly on the dose response kinds of issues. So we did have an expert panel on lead, and we had an expert panel on cadmium, and those were separate panels.
I actually wonder, in light of that, if this should more appropriately be labeled the burden of infectious foodborne, and if it's a different method, and if it doesn't have the depth and range, and if it's a different way of actually coming to conclusions. I'm not sure grafting it onto this as though it's like, like less than 1% contribution to the overall risk is really appropriate or fair, and it's going to lead to, again, something I already think is a bias, which is to focus pretty much purely on infection rather than recognize all those other sources.
Yeah, I think
I'm an outsider to all this. I'm
thinking, no, I'm just thinking, if they haven't gotten that comment already, I think it's an important thing for the core organizing committee to get. So I'll try to
something for the next iteration.
Yeah.
When everybody is recovered from this one. We want to take just the one question from the webinar, and then we should probably close.
So we have one question. How closely are you working with CDC's Food Safety Modernization Act Surveillance Working Group members?
I am not right now. Probably. So I don't know. Well, personally, I'm not right now. The global